Thank you. And thank you for that too long and too kind introduction. You will not get any more strokes on the golf course. Will. Everybody, and I'm sorry you went that long. Now I have to go that long, but I'm not going to because we're running out of time, and we're the last thing before the end of the session. So let me just briefly acknowledge each member of our panel and then get right into the questions, because I've got some, they've got some things they want to say, and then we'll get to questions from all of you. You've got the bios in your package, but to my immediate left is Julie Stoss, who's the Vice President of Government Relations at the Kaiser Foundation Health Plan. To her left is Tom McInerney, who is the President and CEO of Genworth Financial. And then, I'm sorry, they switched, or I switched. To the far left is Tom. And in between is Ray Gilmartin, who was Chairman, President, and CEO, now retired at Merck, and is, of course, another trustee. How do you get all three titles? I never got them. So,
inherited them.
And these are folks that have been and are at the forefront of the issues that Chairman Pitts was discussing and the issues that are incumbent in the paper that CED released today. So, Ray, you were one of the co-fathers of this paper with Ron Williams, and so I want to start with you. You listened to what the chairman said. There was a lot that was in concert with what is in the paper. So I'm going to give you a magic wand. You've got 4 months to implement healthcare reform. Start now. Where would you start?
Well, I think the first place to start is with a refundable tax credit, which the congressman mentioned. That recommendation was first made by CED in 2007 in their report they issued on healthcare at that point. I think since that time, as more experience has shown that other approaches to try to make healthcare more affordable are complex, difficult, and hard to administer. Whereas a refundable tax credit is very straightforward, and we're advocating a refundable tax credit for all. The other thing, if you think about our report, what we're really doing here is through market-based competition, our goal is to transform the Affordable Care Act into one that offers more choices in terms of insurance. And in other words, you can buy the insurance policy that fits your particular needs. You can buy that across state lines. And also that you can buy that insurance policy in a variety of channels, a public exchange or a state exchange or a private exchange or from an insurance company website directly. So therefore, more choice among insurance plans, more choice in terms of where to buy those plans. And as a result of this, we expect there will be increased market competition within the healthcare system, which is the kind of environment that one needs to basically continue the innovation in terms of pharmaceuticals as well as medical devices, but importantly for the future, to continue the innovation that is occurring in terms of clinical practice and the alternative forms of healthcare delivery in lower cost settings. So the key from our standpoint, John, basically is market-based competition as a way to transform the Affordable Care Act into something that's more responsive to our needs as here as patients and also consumers of healthcare, and one that will support continued innovation. I might put in my statement that Steve outlined, the kind of issues that are commonly talked about with our healthcare system, but we should recognize that in terms of innovation, in terms of Nobel Prizes won by US-based researchers, by the number of drugs, 70% that are discovered here in the US, the discoveries in medical technology, the advances in surgical procedures, the advances in anesthesiology, are hallmarks of our system, and we want to ensure that innovation, that level of innovation, will continue going forward.
Well, that's a good opening for the question I want to ask Julie to opine on. It's been interesting, the chairman and Ray in his discussions in this paper have focused on what much of the debate is focused on for the previous several years, and that is the payment side. Kaiser, the Foundation's health plan, has been a leading innovator on the care side. The two are coming at each other. Where do they work, and where are they in conflict?
Thanks, John. I do think, you can talk about quality from the clinical component, but given the forum, I do think it's interesting, the payment side. We do have to incent and pay for quality, but it's more than just pay for performance or quality bonuses. I think you really have to get down to payment reform. When you have a fee-for-service system that rewards quantity over quality, it's not going to move us until we find alternative payment mechanisms. And frankly, the things we know that work for quality, care coordination, case management, patient education, tracking, none of that is compensable in a fee-for-service world. So we really got to move to a new system. I think the SGRC change is really going to be some interesting to see how that plays out in the policy world. So that was not only increases for physicians over time, but there's increased incentives when physicians move away from fee-for-service to payment alternatives. So I think that will be an interesting experiment to see how that plays out. I think the other thing that's really important is rewarding those plans who do invest in quality. One thing that we've really been disappointed at the speed of implementation at the ACA is implementing quality ratings. That is something that is supposed to have been done. It's not in the federal marketplaces. We'd actually like to see in the exchanges at the point of purchase for consumers meaningful quality ratings and actually rank the plans by quality. We know from experience that how often you are chosen is directly correlated to how far up you are on the search. So the first couple pages do better than the last couple pages. I think you could do a lot to really direct people to quality plans just by getting consumers meaningful information for them to be able to pay for, to recognize it.
Julie, thank you. Tom, I'm going to bring you in the conversation. Obviously, that's why we're a panel. A lot of the discussion has been around the here and now. The current state of payment, the current state of care, the costs, and the challenges that we have. But you look at the long term, and your business is focused on the very, very long term, and how health and care is provided in it. So when you look out the 12, 15 years, what are the challenges that you see, and are they being addressed? Will they be addressed in what you've read here, and are they being addressed at all by the Affordable Care Act or the changes that are coming up?
I would say, John, that one of the things that worries me about the future is the Affordable Care Act is very important. It affects a lot of people. And I think, as both Ray and Julie have said, and the congressman before, the Affordable Care Act did a good job, I think, or a reasonable good job on expanding access, but it didn't do much at all regarding quality and affordability and cost, and that's a big part of the recommendations that CED and Ray and others have worked on. But I think it's wrong to just look at the ACA in its narrow state, because in addition to whatever the cost that taxpayers are on the hook for the Affordable Care Act, they're also on the hook for all Medicare payments. They're also on the hook for Medicaid, and they're also on the hook for all the health costs for the Veterans Administration. I think if you add up all of the liabilities that the government is responsible for, and ultimately the government's taxpayers are responsible for, it's over $100 trillion today, and it's going to get worse because today 10,000 baby boomers turn 65 every day. The oldest boomer is 69, so in 11 years there will be so many thousand baby boomers turning 80. I don't know that it will be 10,000, but it will be not too far below that. And if you look at, and I've, in my career, I'm sure Ray and maybe you as well, John, have spent a lot of time in other countries and overseas. And I think if you want to fast forward 20 years from now, look at Japan today. Japan has had 20 years of a horrible economy, poor growth, and a big driver, a lot of reasons for that, but a big driver is demographics. They have a rapidly aging population, much worse than here, and they also have a shrinking population, and they have by far the highest cost of government programs, and their debt to GDP is well beyond the U.S. and most other OECD countries. Europe is starting to get there. You see it first in Greece, and primarily because in Greece it has a small private sector, and you can retire in Greece at, I think, is under age 55. You have the government health programs as well as retirement. So we're seeing it in Greece, but it will, it's starting to occur in France and other places. So back to your question, when I look out 15 years, and with, let's call it 7,000 or 8,000 baby boomers turning 80 every year, living longer, generally not all that well prepared for retirement security. They don't have defined benefit pensions. They have whatever they say, 401k. The average is about $100,000. And if you look at, today we just released a study a couple weeks ago on the cost of a private room in a nursing home. On average in the country, it's over $91,000. It's going up over 4% a year, between 4.2 and 4.5%. So, in 12, 15 years, you can expect that 91,000 will be over 100,000. And if the average baby boomer has saved about 100,000 in their 401k type plans, it doesn't take much in terms of a healthcare problem in the family to really cause enormous problems. And ultimately, there's only about a little less than 9% of Americans have long-term care coverage. So 92% therefore don't. And the ultimate payer is Medicaid. And so I think if you look at the Affordable Care Act and what the CED is recommending to approve it, but then you also look at Medicare, Medicaid, the Veteran Administration, health-related responsibilities, it's enormous cost. So I think the focus of the CED and the report on, access is important, and we all agree with that, but getting the cost and the quality down, I think, because not only do we have to worry about the cost of the ACA, but also those other entitlement programs.
So if I could follow up on that, John, so I agree completely with what you have to say. And moving beyond your 4-month time frame, the next stage for CED is to take on a policy initiative, to develop a policy framework, if you will, for Medicare. Because without addressing the issues in Medicare that you outlined, it will ultimately overwhelm the market-based approach that we're talking about as a way of transforming the ACA. As a matter of fact, the reimbursements within Medicare are real distortions in the marketplace in terms of the inability really for the system to take advantage of the delivery of care in lower cost settings because the reimbursement mechanisms hang up the pricing, if you will. So we don't get into real true pricing competition. So that's our next initiative for the reasons that you've outlined. And I think that the philosophical approach is that we'll take is similar to what we took in this, which is market competition is the best at stimulating innovation, controlling costs, and improving quality. The Congress made reference to Medicare Part D, which in my PhRMA days, I had an opportunity to be involved in, and we were advocating what at the time was quite controversial, which was a market-based approach, because at that time, market-based approaches were really not considered to be feasible. Yet, by having competing health plans deliver this new entitlement, there's high levels of satisfaction, high level of quality, and as the Congressman laid out, it's well below budget, and something like about 40% lower than the original
44, but who's counting?
Pardon me?
44, but who's
44%
counting?
below the Congressional Budget Office estimate. So that, so I think what we're about here is a really fundamental philosophical shift in terms of how to think about the delivery of health care away from sort of a more heavy role for government directing the allocation of resources to a much greater role for the market in terms of allocating resources and achieving the efficiencies that you're looking for.
Well, that comes back, and I'd like Julie to comment on this, because you spend a lot of your time in the States, and that market is now being transferred so that if we're on this trajectory under the Affordable Care Act, we will have the preponderance of the bodies, the patients being controlled in the state level, not at the federal level. Now, so are our states prepared to do this? Do the insurance commissions, do the decision-making processes that are occurring in the governor's office and the state legislatures, are they able to deal with this, or are you having issues with those states as they have their increasing role in health insurance?
Well, so we've long been a state-based regulation, and I think it's important that the markets are local. The providers are regulated at a local level. The hospitals are licensed, physicians are licensed. And so we've been very comfortable with the state-based regulatory system. You do have some inconsistencies between states, but I think that the National Association of Insurance Commissioners have really committed to trying to find ways to have uniformity and to address needs of plans that are in more than one state. We do get concerned if there's multi-state participations or plans if you end up with a dual regulatory standard. So, we are in a state, if we have plans coming in who aren't held to the same standards, the same levels of consumer protections, the same benefit requirements, it really creates an unlevel playing field. So I think that's something you have to look at, is making sure that the markets are fair if you are going to have some state-based, and then if there's some exemption from that, we would want to see them playing by the same rules. But I do think they're equipped, and I think you have a role for state regulation given how different and unique each market really is.
So while you're on that topic of state regulation and the states, you went to law school, you went to Harvard.
I did.
So did Ray. Tom, did you go to Harvard?
No.
Me neither. At law school, how's the Supreme Court going to rule? More importantly, if it does strike down King v. Burwell, if it does rule for King, what happens in the states? What does Kaiser do to serve the portion of the 8 million that will lose their insurance, the 8 to 10 million that will lose their insurance at some point after that decision?
I'm certainly not going to predict what too smart for
I
that,
can't
although I
imagine.
have my guesses. But I think a lot of people got it wrong when the first main case. I don't think a lot of people saw the Medicaid ruling coming down. So I think we've all learned not to guess, at least not publicly. But I did think it was interesting, the congressman was talking about what would be playing out at the federal level. But think of the political pressure in those 34 states. It is one thing to object to the ACA on philosophical, political grounds, but when you are taking away actual money from consumers, I think there is going to be incredible pressure on those states and those governors and legislatures to do something. And if there's not some sort of compromise or fix at the federal level, my prediction would be that you're going to see a lot of technically state exchanges, but not called state exchanges, but they're going to waddle and quack a lot like state exchanges. We'll have to see how much room the Supreme Court gives, but that would be, I think the states will just have to come up with something. I mean, it's just untenable to leave people with a requirement to purchase insurance and not give them the financial support that they need to do that.
Tom, part of what you talked about and part of what you're grappling with every day from a long-term standpoint matches the healthcare system in the time frame where most of us will be having the greatest expenditure of our healthcare dollar in the final periods of our lives. We don't have a good way to value that healthcare at that period in our life. When you look at it and when you think about it, how do you value and put a value on an extra 6 months of life, an extra year of life, an extra 2 years of life at the end of your life, whenever that comes? How do you look at that, and how do you provide for that, or how should we be providing for that and thinking about it as we age and as the population ages?
John, one of the things that we launched last year was Let's Talk Tour. And the focus of that was to have families talk about these health issues, and particularly health issues, long-term care. Over 50% of long-term care claims are related to cognitive or dementia, Alzheimer's type diseases. And, there isn't a one-size-fits-all. I would say that's perhaps one of the ACA issues we sometimes try to make it, one-size-fit-all. And so what we've been encouraging families to do is to have a conversation. And so this would be perhaps the grandparents who are over 80 now, and the parents, baby boomers or younger, and then their children and ultimately their grandchildren. The children and the grandchildren should care because whether they know it or not, everyone says, well, the government's going to pay for this, but it's really them. Our kids and grandkids are going to pay for it. So they have a stake in, how much payroll taxes and future income taxes will have to go up that they'll have to pay. And then clearly, when you actually have those conversations, we find many who are either disabled or are worried about becoming disabled, they don't, on average, want to become a burden to their families. And so I do think that through having those discussions and living wills and those kinds of things, you do find that in most cases, the impacted individuals have said, I don't want to have unusual medical treatments, and therefore, we would hope that, because I don't think there's a government answer, certainly there's not a private sector answer to what's right for families. I think it should be made at an individual family level, and then once those decisions are made, hopefully we can design a system. And tort reform was briefly mentioned by the congressman. I know it's in the CED. I think that's also something that's important, that we shouldn't have either the government or the Justice Department somehow weighing in and saying, well, whatever families think, we think better. And so hopefully we'll have a lot more discussions within families, and it will become easier for families working through whatever parts of the medical system or health system they're involved with to make those decisions. Because I do think, it is clear whether you're talking about Europe or Japan, China, U.S., all with aging populations, a lot of money is spent in the last 6 to 2 years of life, and whether or not, from a quality perspective, the cost that's spent is worth it, is harder to say. But I don't think we ought to have, a government panel or some other group of outsiders getting involved. I think it really should be up to the families and ultimately, obviously, their physicians and healthcare providers.
And I want to get to questions from the audience, but that drives me to a question for you, Ray, and that is that has been a lot of discussion about the costs of therapies, both in our industry as well as across the medical spectrum, and the increment of time that they provide and the quality of the time in life that they provide. When you sit back and think of it, and you think of the healthcare system as a whole, how should we be thinking about innovation and paying for innovation and measuring those innovations, given how the science is driving them?
So I think a couple of things along those lines. One is that in terms of, let's say cancer treatment and so on, that in terms of that additional 6 months is also an additional 6 months often of research in terms of discovering what is efficacious and what new insights might be gleaned from that patient experience. And so therefore, I think that's important for innovation. Secondly, in terms of the cost of therapies, that when we were involved in the Medicare Part D, I would say that some were concerned about the impact of increasing the power of prescription benefit managers and health plans. And the response that Merck had and I had to that concern was that prices are going to be controlled in some fashion. Either the government is going to do it the way they do it in the rest of the world, which would be a real disadvantage to innovation, or it's going to work, can be controlled or driven by the market, by market competition. And fortunately, we came down on the side of market competition. So if you look at the power of health plans and the power of PBMs to have created true price competition within the pharma industry. That's been, I think, a real benefit, both to the companies who basically have to become more efficient in basically the drug discovery process and how they take drugs to market. It's certainly been a benefit to the healthcare system and to the patients of having more affordable drugs. And I think a clear demonstration of that, and I'm speaking now from what's public information in the papers, is over the hepatitis C drugs.
Right.
Basically, Pharm came out, very high priced drug. A competitor came out with a significantly reduced cost. The health plans put the second drug on the preferred position formulary. The first company responded. So I think that driving competition is a way to deal, and this would be across the board in the healthcare system, is a way of basically having affordability. And on the payment mechanisms, you've got more experience, but I believe that market competition among healthcare providers and the benefits that a change in payment would provide in terms of competitive advantage would be a very strong incentive for the development of integrated care and the ability to therefore deliver more effective and lower cost care. So that's why we're such strong advocates of introducing more market competition into the healthcare industry. There are always winners and losers when that happens, but there are not as many losers, and a lot of losers who thought they were going to lose actually come out on top.
Julie, you're not going to let that lie.
I couldn't let that go,
Right.
sorry. So
Listen, I told you I wouldn't go with you into this, but
well, I certainly agree that competition is the way, and it is interesting in delivery systems. I'll often say that they're kind of Kaiserification of delivery systems, and that's not something we fear or worry about. We invite that, and that was actually the original theory for managed care, was supposed to be competing systems that were competing on quality and cost. So we welcome that. In the price of drugs, I absolutely agree, when there is competition, that is best to have a market rather than setting prices, and we certainly want to incent and pay for innovation, but I think we have really reached a tipping point where we have to ask at what cost and at how much, and is not truly a free market that we're competing in. There are certainly plenty of governmental advantages given to drug companies, and it's not out of the goodness of their hearts, right? It is to create enough financial incentives that you have the investment in these life-saving therapies. I think that comes with a social contract that you then don't price at a point of whatever the market will bear. And the Hep C drugs, it is a tale of competition working at a point, but I think it's like a department store when you've got a huge markup and then there's a 40% off sale. It's still really expensive, and I think when we're looking at affordability, we are all going to have to look at our cost points. And you talk about the value of a drug, and that's, I think that's really our value of society. It's a dangerous framework, because you think about, if a surgeon has a life-saving therapy for your child, what would you pay? I would give you my every last cent. I would say that is a strategy that will lead us to bankruptcy. We have to look at cost and certainly reasonable profits and incentives for innovation. But if it's whatever the market will bear, then as a system, that's never going to get us away from having 17+% and growing of our GDP. So I would call on all of us to look at, who are in the sector, to look at what can we do to lower our own cost structures. And I think we all have a role.
I think that's the key. I'm in terms of, you can pick out any one sector of the healthcare, but there's tremendous opportunity across the board, basically, to deal with the cost structures and the inefficiencies that we now have. And so our mantra in our report is competition, competition, competition. And that's true for the pharma industry. We now have biosimilars, which deals with some of the problems with biotechnology. We have basically very facilitated approval of generics. We have the PBMs and health plans being very powerful in terms of keeping those costs at a reasonable level. So the idea is to keep introducing multiple competitors into this market, and we're advocating the same thing for the healthcare delivery system in general.
Tom, you wanted to say something, and then I wanna
Yeah,
go to
I
the
did because, I think there's, sometimes we view a lot of these issues from a U.S. perspective. I worked for a Dutch insurance company bank for a decade and lived in Europe for several years. And, it's funny, when I lived there, as they watched the whole Obamacare, ACA debate, they were on the one hand surprised that the U.S., big country, they sort of looked to us as experts in everything, didn't have a national health system. And that would have been earlier last decade. But by the end and now, what has become interesting is they now, my Dutch friends would say, if I break my arm, I'm going to have it fixed in the Netherlands. But if I have cancer or heart problems, I'm going to the U.S. Because one of the advantages of their system is that there's universal coverage. They have very high taxes. The average tax rate in the Netherlands is that they actually pay is close to 50%. The top is 52%. And there is very significant challenges in their economies. Job growth is terrible. Unemployed for the youth is terrible. And ultimately, they, like us, have a pay-as-you-go system. So if the younger generation of jobs, then who's going to pay the taxes? But you are seeing across Europe enormous problems with the fact that these pay-as-you-go welfare entitlement programs are just not sustainable in populations that are aging. So I do think that while there is certainly a role for government, and I think the CED supports that, I do think that the problem with government in the end is the government doesn't make any money. They tax people. So it's really the taxpayers who are going to have to fund at the end whatever we decide. And I do think that it's pretty easy to demonstrate over the last 50 or more years that in general the private sector, the market, does a better job in keeping costs down through innovation and competition. And I think for taxpayers across America, there is a lot riding on both parties getting this right, because the easiest thing that to cover was access, and I think the Affordable Care Act did a reasonably good job on that. But it's done very little on quality and cost, and I think quality matters for sure. I think we probably still do have the best quality because of the innovations and the value of the drugs that your Merck and other companies have done, and you said the 70% here. So the quality is all about innovation, but the cost, these are staggering costs. We don't have a fund that we're earning interest on to pay for it. It's all taxes for our children and grandchildren. So I think at the end, whether you're more a for government solution or a private solution, in the end, there's a role for government. But if you want to have a chance of having a reasonable tax rate so that you have a macroeconomy in the U.S. growing at a reasonable rate, and it's not growing at today it's 2% or a little below. It's been historically 3 to 4%. So we've guaranteed all these entitlements. We've had what has been a spectacular 50 years of growth in the U.S., 3 to 4%. But I think those days are over. And I think when you look at, again, whether it's the ACA or Medicare or Medicaid or Veterans Administration, this long-term care looming crisis, I mean, there is a limit to what, in the end, taxpayers can pay without severely damaging the ultimate golden goose, which is the economy and the jobs and the ability for people to earn enough to be able to pay a reasonable amount of taxes and still, live decent life. So I think it's all connected.
John, just one follow-up.
Okay,
About
then
CED report.
question, sure.
Is that, so I think you put your finger on it. I mean, one of the standoff in healthcare for a long time, even today, in terms of how to move next, is the difference in perception about what is the role of government versus the market. And recognizing that in our report, we have basically put together, hopefully, a policy framework that addresses the concerns and also meets the objectives of those who see more of a government role, and at the same time addresses the concerns and also meets the objectives of those who basically favor a more market-based system. So I think we've got the balance right. We'll find that out as we go forward with this. We are more in the direction of the market, but at the same time, there is, as you said earlier, a role for government, and our report recognizes that.
Ed, I want to open up for questions, but Steve, apparently we've suspended the laws of thermodynamics because what was 2.5 minutes has now become 9.5 minutes, so time is going backwards. Okay, we have a couple of our colleagues here with microphones, and first one she hands it to, we'll go, oh, here we go. Here
I just want, while it's fresh, I want to pick up on some of the comments that Julie made. Just as an example, sometimes examples help to understand what the dilemma is. I have a friend who is taking one of these targeted cancer drugs, and he received a call from the insurance company saying, we're going to deliver it tomorrow. And he said, well, that's okay. If I'm not there, just leave it on the front stoop. And the insurance company said, well, we will, but if it gets stolen, it'll cost you $10,000 for a 30-day supply. So, I start thinking about that and say, and that is probably under some patent protection, so competition may not be able to come in to help defer the cost right away. So then you start asking the question, are they pricing this on what the market will bear? Or are they pricing it on what would be a fair profit? And how do you ensure that when you start talking about those kinds of costs, that there's some sanity in the process?
So John is the head of farm.
I am the moderator here, and while I have many opinions and great facts to support my positions, I'm mindful of my role as the moderator. So I won't step in, but I have a sneaky feeling Julie wants to say something.
Well, I think you framed it correctly, and I don't have the magic answer, but I do think we have to look at. Are we incenting the right innovation? Are we, rewarding Me Too drugs as well? How long do you reward past innovation? And it's certainly not saying we should move to price controls, but that we need to kind of look at the system. And there is exclusivity. There's the government is prohibited from negotiating with drug companies and Medicare. There's rules that make it difficult to negotiate discounts for private payers. And again, there's a social contract. There's a reason to do that, and I'm not saying that you take all of that away, but I think we have to examine if we've got the balance right, because we don't have the check.
Let me just say one other thing is that those are all questions that should be explored and have been explored and get fought out. Yeah. Let's keep in perspective, though, that 10 or 20 years ago, pharmaceuticals were 10% of the cost.
Actually, in 1960, they were 10%, and the CMS projects that 10 years from now, they will be 10%.
So
I think they're at 13 and growing.
No, it'll go back down. It'll go back down. This year was an anomaly because we have 11 million more people buying them.
But this is a good point to discuss, because let's focus in on where the costs really are in the healthcare system and what the opportunities are. The good work by Kaiser and others, but for the first time, as a result of some of the market incentives that are now built in, we see hospitals really making some extraordinary gains in their quality, and also looking and be very cost conscious. And I think in that way, that's where we're going to get the big impact on affordability. So I will stop because you
I want to get to another question, because we're going. We can just curve time so long here.
Okay, so I have a question about the CED recommendations. So the Affordable Care Act provides a refundable tax credit that's tied to the value of a low-cost plan. So I'm just wondering what the real difference is, and it's been shown, really that structure has resulted in a lot of competition, and the dynamic that you're seeing around narrow network plans that have exerted price pressure on hospitals I mean, the trade-off would be you could have a refundable tax credit that does not phase out with income, but then it would cost a lot more. Or you could do a flat tax credit that wouldn't cover nearly as much of the value of the plan. So I'm just wondering what exactly the recommendation there is. And then secondly, the proposal on across state lines, I think that the biggest barriers to entry for an insurer into an insurance market are really the cost of establishing a provider network and the inability of a new entrant to establish market share such that it would have enough bargaining power against providers to get good prices and have low premiums. So how would that proposal really be that effective? How would you address those two issues?
So the first one is, I think the Affordable Care Act would be better characterized as providing subsidies, not a refundable, but providing subsidies for the purchase of health care that are quite complex. Well, it does, because in the CED recommendation to address that specifically is to have a refundable tax credit for everybody, and at an amount that's set at the basic plan in your region. So simple to administer, it's not means tested. It's rather than subsidies for a few that are complicated, it's a refundable tax credit for all that you can use to purchase insurance. On the second point is that there may be some difficulties insurance companies have of putting together a network. On the other hand, a lot of the differences in cost have to do with what states have put into, mandated into the insurance policies that make them more costly. And so therefore, by being able to choose across state lines, you get an immediate benefit by buying a plan that fits your need and not something that's been mandated through the regulatory process.
Well, Newton has come back, and and he's standing now. So we could go on forever on this very, very important topic. But please join me in thanking Tom and Ray and Julie for some great insight.